Welcome back, everyone, to another fabulous episode of the Healthcare Trailblazers podcast. I'm very excited to be sitting here today with the wonderful Andrew Schwab. Andrew is a very talented person, been in the space for about 20 years, working across multiple very interesting organizations, including AARP, and now most recently Oak Street Health, who is now acquired by CVS. So very exciting, a lot going on in the space, and Andrew is right in the thick of it, specifically when it comes to government affairs, coming into organizations and building out just these various processes. And a lot of organizations didn't have any infrastructure from that perspective, and coming in and really building one after another. So I'm excited to talk about all those experiences. Andrew, thank you so much for joining with us today.
Thanks for having me, Mindy.
Absolutely. So, all right, take us back. Where'd you grow up and why healthcare?
Good question. I think when I think about my career, it all makes sense when you look at my LinkedIn profile, but it didn't feel that way as I was going through it. And I'm really kind of smack dab in the middle of the 40 or 45-year arc of your career. Thursday will be 20 years since I graduated from college. I grew up in Teaneck, New Jersey, about 5 miles west of New York City. My dad was a high school principal and English teacher, and my mom was like an office manager at a company that recruited and supported focus groups.
Okay.
But I originally went to Syracuse University, and I bleed orange in a way that my wife would tell you is likely unhealthy. But I originally went to Syracuse because they have a wonderful and respected and world-renowned communications program in the Newhouse School of Communications. But I kind of caught the political and history bug almost immediately. On the first day of college, I took Introduction to the Analysis of Public Policy in the Maxwell School of Citizenship and Public Affairs, which is the other kind of major flagship at Syracuse. And the kind of TV thing went out the window. And so the story goes, I got to senior year and I was kind of trying to figure out what I wanted to do. And I started writing letters, to Democratic presidential primary campaigns.
Okay.
Didn't get much uptick. But my local state assemblywoman for Teaneck, New Jersey, where I grew up, who later became the state Senate Majority Leader, Loretta Weinberg, read my letter and brought me in and helped me network with no connections, either family or personal or professional, into New Jersey politics. And so I worked for Senator John Corzine for 2 years as deputy press secretary. It was a great training between the first and the fifth largest media markets in the country in New York and Philly.
Wow.
And then when he ran for governor, the lady who is now my wife did not want to move out of the New York metro area in northern New Jersey. And so I networked my way into a gentleman who was running for the state legislature for the first time.
Okay.
It was a competitive race. We spent a lot of money before redistricting, and the seat got a little bit safer, but he got elected. And 2 years into the 7 years that I worked for him as his chief of staff, he became chairman of the Banking and Insurance Committee.
Okay.
And that's where healthcare happened.
Okay.
That's where all of the knowledge of healthcare, health insurance, and things like that started coming into my my skill set. Passed 23 laws in the legislature. Very proud of my public service, my 7 years in the legislature and 2 in the Senate. And then in 2013 came down to Washington and got into professional government affairs and advocacy, first at AARP and then at other trade and member associations and nonprofits.
Amazing. So let me get this straight. So you literally wrote a letter to someone in government and they got back to you?
Yeah. I think
an email or in physical mail letter?
Well, it was a physical letter in the spring of 2003. And I think, Mendel, it's a really good example of kind of an Americana moment, right? Like these elected officials, we should treat them with respect and deference, but elected officials in America are responsible to us. And my local state assemblywoman saw that I, one, had graduated from the same college that her late husband had graduated from. And 2, saw that I was a young person interested in politics from the town that she represents. and they called me in,
Right.
and I guess something popped, and I was able to kind of navigate my career from there. But it's these little moments
Yeah.
that really kind of take you in brand new directions, and my career is littered with those little cool moments.
Yeah. Just, was it one letter? Was it multiple letters? How many times did you have to write in?
It was one letter. So I will
That's
share
amazing.
this. I do many things poorly, and my wife will be first among equals to tell you what they are. I write really, really well. My
Okay.
dad was an English teacher. My grandfather was a magazine editor. It's something that's very important to me. I hope that original letter, maybe made an impact because of that training that I had.
That's
I like to say, my dad was heavy with the red pen, even in high school.
Gotcha. But another thing I want to point out is the fact that you wrote a letter, is the fact that you took the initiative and you took the you made that step. You know what I mean? A lot of people, they think, it's not going to work. No one's going to read this. No one's going to look at it. So why try? Why bother? But it seems like the cornerstone of your entire career, and you're looking back, whatever amount of years later, was the fact that you even though it didn't technically, you probably had a relatively low chance of her reading it, but you actually picked up your pen and you took a paper and you wrote a letter and you mailed it out. I think that's an incredible thing. It's a huge lesson for people. A lot of people, they think,
I think that's right, and I'm thankful that you point that out. It is, again, it's like this kind of nice piece of Americana that actually worked out.
Right.
By the way, I mentor a lot of young people. It's something I get great meaning from. And to this day, when they're starting out, my advice is write an email to your member of Congress or your local state legislator, put an interesting subject line, say, I am a constituent, I live in your district, I'm interested in this world, and see where it goes.
Yeah.
And you get 1 hit out of 10, that's a win.
Yep.
And it could lead to something big.
Yeah, absolutely. Okay, so then, you fast forwarded, you're in DC. What kind of law were you working on before you transitioned into healthcare and starting to learn about health insurances and Medicare Advantage and all that?
Yeah. So, when you are a political staffer, as I was for the first 10 years of my career, the things that you are interested in really are the things that your boss is interested in. And so Assemblyman Gareth Sher, who remains in the legislature all these years later as the Assembly Policy Chairman in the New Jersey General Assembly, originally was kind of like, right, the first term, you're just trying to figure out what you're doing and
Right.
trying to create an operation. I opened up his office. I hired a small staff. He was always interested in healthcare from the beginning. He had been on the board of trustees of the local hospital. And so that was really a time that was the beginning of local, sometimes urban, but rural hospitals really having trouble with their financing. And so one of the first things we worked on was like a new funding scheme for hospitals and a loan to that local hospital in Passaic, New Jersey, that we had to work closely with the governor's office on. And so that was really the beginning. And then one of the other bills we quickly worked on was requiring training for hospital trustees in financing and healthcare.
That's a good idea.
Shocking that was not a requirement in the state of New Jersey at the time, but my boss, who had experience as a hospital trustee, wanted to make sure that was something, and that's been law now for almost 20 years in New Jersey.
Interesting. And yeah, that does make a lot of sense. So, you said how it took almost a year just to find your footing. When you're a new administration, you're coming into the job, and when you talk about leadership, I think that's something that so many people don't fully appreciate, that things take time and people expect things to move so quickly. And for you to sit there and just say, like, I don't even think you realize what you said, but you just so casually said, yeah, it took us a year to get our footing. And then we did, all these incredible things. I think a lot of people, they lose patience very quickly. They expect things to just move at the same speed that they would like it to. And then when that doesn't happen, they burn out. So, how was that something that kind of in hindsight you were able to look back at, but during you were impatient, or were you always able to come into a role and expect to kind of, have that natural flow and things take as long as they did?
By nature, I'm an impatient human being.
Okay.
It has been a lifelong battle, but I think one of the things I bring to the table is I'm very honest with myself, or at least I try to be. Um, and so you have to focus on the fact that over the long term, things do start to move, and hard work and sound strategy does not always, but in general, pay off.
Right.
I think that's a lesson that I've only learned in the past few years. That in advocacy, in public policy, there are lots of things that mold what eventually happens. But a lot of it is, I have this good idea, I have some good data, I have a point of view. You need to kind of combine that with respect and relationships, because this is America, and policy does not happen in a vacuum, and it certainly does not happen alone.
Yeah.
And it still remains a good and sound strategy to make sure that your policy is bipartisan. Those are the things that last. But that longer term view is something I'm only really starting to see now, in my early 40s.
Yeah. No, it's difficult. So I have this theory that I'd love to hear your take on. My theory is that it is almost impossible for a human being to think ahead of themselves in a specific thing that they're in farther than the amount of time that they have already behind them.
Mm.
So when someone just starts in business, if you told them this lead is going to take, if someone starts in sales and you told them, this lead is, you'll land this lead, it's a big client, but it's going to take you 3 years. They'd be like, dude, get out of here. No way, right? Because they have a week behind them. So if I'm not closing something in a week, then don't talk to me about it, right? But then you see someone that's been in the game for 5 years or 10 years or 20 years, even more so, all of a sudden that ability to think ahead starts broadening greatly. That's my theory. What do you think?
I think there's some truth to that. It's an interesting idea. I think that one of the distinctions is if you are trying to hustle to pay your own bills and you have personal financial constraints, right? You're going to be your need is a little bit more acute, and your time frame is shrunk. But if you already have some backing underneath you, or if you have a stable financial position from which to operate, I think then it's much easier to take a longer term view. Listen, let's be very clear. I've never started my own business. I worked for the government, with last time I checked,
Right.
is not going out of business. I came to Street 19 months ago after they had already become a public company, right? So I had those luxuries to think more long term.
Right.
But I think that your theory is I would say is correct with those types of
more entrepreneurially minded. That makes sense. That makes sense. Which brings me to another question. In the context that you're describing, where you have financial stability and you're working for the government, which if they run out of paychecks, they print more money. So not a big issue there. How do you not get complacent and just not get things done and become just one of these government people that are just a lifer and just take, cashes those checks, and you lose your entire drive?
Well, so I think let's also be clear. I haven't worked for a government entity in a decade.
Yeah.
Right. I am personally very goal oriented, and I have a tendency and bias towards action. I honestly think that more advocacy is always better advocacy. That doesn't mean that you should be nonchalant or lack a strategy, but you kind of need to pick out, for us at Oak Street, at least, your 3 public policy priorities and just keep at it. And we are slowly but surely starting to see that at Oak Street Health. And I'll give you one quick example.
Sure.
Our number one federal priority at Oak Street Health is to better link the social determinants of health to quality and payment in Medicare. For about 7 or 8 years now, there's been large policy consensus that the social determinants of health are really important to your overall health. And that, in theory, if you ameliorate some of those social determinants of health, you will bring costs down.
Yep.
Over time. Unfortunately, we've not put much money behind that in Medicare in particular, right? And this is the United States of America, and not much happens unless you invest in it.
Right.
And I think that's the right frame for thinking about this. So We just saw the final regulation come out for STARS ratings, not to start until 2027, but for a health equity index reward factor in Medicare Advantage. And that will incentivize, we hope, health plans to invest and attract Medicare beneficiaries in Medicare Advantage in underserved communities, in which almost all Oak Street Center health centers operate in. Mm-hmm. And so I've been here for 19 months, and that's like the first little thing that I think is important. And now we got to keep going. And my job is to keep going, and you get a little bit of a win, and you feel good about yourself, and you keep going.
Yeah. I love that. So before we get into the exciting things going on at Oak Street Health, you worked for a while at AARP in between, and there may have been maybe a couple other stops. So let's talk through those. What was that AARP experience?
Yeah, so it was my first job here in Washington. I was on what was then known, or maybe still known at AARP, on the government affairs squad there, known as the Federal Health and Family Team.
Okay.
And I had a specific bucket of issues, and that included the Affordable Care Act, employer health insurance, Medicare Advantage, and Medicare Supplemental, otherwise known as Medigap, right? Mm-hmm. So AARP's, a senior advocacy organization, arguably one of the most powerful advocacy organizations in the country. And so I was there in the beginning in 2013 when the, House Republicans were really trying to come after the Affordable Care Act and target it for defeat. And so there was a lot of education going on and things of that nature. It was also the time when the Affordable Care Act had required parity between Medicare Advantage and traditional Medicare payments. And so everybody thought that would decrease MA enrollment. But as we know now, the opposite happened, and it went, straight up in a very fast trajectory. And just last week, the Kaiser Family Foundation said that Medicare Advantage is now officially 51% of Medicare enrollment. And so that is an entirely different set of issues, which I'd like to talk with you and your listeners about as well. But so AARP was great because it was so vast and there's so many resources. And I like to say I got a PhD in federal health policy while I was there, because they were very supportive of me going to talks and getting kind of established in the healthcare firmament in Washington.
So let's talk about that. What is the host of issues now that 51% of Medicare enrollment is in Medicare Advantage plans?
Yeah, I think so. I start from the position that the current Centers for Medicare and Medicaid Services leadership's goal, very publicly stated, is that they want 100% or as many as possible of Medicare beneficiaries in some type of an accountable care relationship by 2030. That's a short 7 years away, right? Right now, the primary place where value-based care and accountable care happens is inside of Medicare Advantage. And so we can have this very important debate about the finances of Medicare Advantage and prior authorization, and we should have those conversations, and those are critical and important. But as we go over the 51% threshold, I think there's a new place that we have to add, a new space we have to think about inside of Medicare Advantage, and that are providers who practice in value-based structures inside of MA. Mm-hmm. And I think that the advance notice or rate notice debate that we had in early 2022 really was the first time when health policy thinkers thought to themselves, wait a minute, this is not just about insurers. This is also about providers like Oak Street and other companies like that practice value-based care inside of Medicare Advantage. And so there's going to be a new debate, and I would like to be part of that for Oak Street Health. And I think there's a debate with advocates, Medicare advocates, with insurers, with providers, about what this new future looks like and what providers need inside of those structures.
Okay. Explain a little bit more.
For instance, on one thing we just touched on was the social determinants of health, right?
Yeah.
Our our providers, one of the things that Oak Street does really well is if one of our patients goes to the hospital, we essentially catch them when they come out.
Right.
And that's why we've reduced 30-day readmits by 42% versus Medicare benchmarks.
Okay.
There are benefits to an accountable care relationship in a Medicare Advantage plan inside supplemental benefits in MA that are very helpful to our doctors when they are trying to make sure that our patient does not go back to the hospital. Remember, Oak Street and our providers have put it all out on the line. We say that we can keep this person happy, healthy, and out of the hospital, as we like to say.
Right.
And we pay for that hospitalization either when they go in the first time or the second time. So
Oak Street Health is a full risk organization. Okay.
And so it behooves us and the health and wellness of our patients to really catch them when they come out of the hospital. One really great way that Medicare Advantage does this is with a supplemental benefit known as post-acute discharge meals, where meals can be sent to that patient's home after they get out of the hospital, and they don't have to worry about the important nutrition you need if you get out of the hospital.
Okay.
That is a viewpoint that we bring to the table, that our providers bring to the table in that debate about how to work in value-based structures inside of Medicare Advantage. And that's just one of those things.
So just for our listeners, if those aren't fully familiar, instead of me answering this question, just quickly, just blanket statement, what does value-based care mean to you for the complete novice, someone that just picked up the podcast and is listening? What does it mean?
So value-based care is a structure in which providers and sometimes insurers are responsible for the health outcomes of their patients. So, a Commonwealth Fund study came out about 2 or 3 or 4 weeks ago that said about 74% of healthcare, primary care in the United States is still fee-for-service, right? You go in, you get paid, your patient goes home. What that does not provide for are all of the supports around a patient that a patient might need, particularly the ones in the underserved communities that Oak Street Health serves. Social work, behavioral health work, help navigating your insurance coverage, community health worker assistance, transportation to and from your appointments, right? In fee-for-service, you're not incentivized to provide any of those because you're only being paid for services rendered. In value-based care, it's one-stop shop. You get, the provider gets a set per member per month amount from whatever payer they are contracted with. For Oak Street, it's usually a Medicare Advantage health plan or a CMMI model. But if our patient goes to the hospital, we pay for that. Right. We are at full risk for that. And that incentivizes us to build all of those structures around our patients to make sure that they only go to the hospital when they absolutely need it and don't use the emergency room as their primary care physician.
Yep.
I want to be very clear. When our patients need to go to the hospital, our providers send them to the hospital. But if we can deal with it in-house, we are going to try to do that. And it saves the money system, and it's far better on our patients because, hospital-acquired infections are a real thing.
Right. Yeah, it's fascinating. And that I've said this a couple of times, but the best way to bring it out is basically the things that will make you the most money in fee-for-service will lose you the most money in value-based care. And the things that will make you the most money in value-based care will, but the question that I've been debating with some people offline recently is that there's equal, because the question is, okay, well, how do you determine that PMPM rate, right? And the answer typically is you're looking at the bench line, you're looking at the baseline of the complexity of your patients, and you're saying, well, this is typically how much it costs us to manage these patients, and then based on that, you're making some sort of calculation. And the question is, well, now there's room for and I'm asking this to you as a policy guy, there's room for fraud or whatever it is, where you just start overcomplicating your patients. So where in fee-for-service, the issue is maybe that from a data perspective is that patients weren't coded correctly. Now, possibly there's room for providers to come in and make their patients look overly complex so that it looks like they're doing such a great job managing these patients when in essence, they don't actually necessarily need that level of care. Do you have any thoughts on that side of it?
You can't speculate or talk about what other value-based primary care organizations do. What I can tell you at Oak Street is that we have an internal policy that only the healthcare provider who provided that direct care can put codes and make a diagnosis. And that is an important part of what we do to ensure that our doctors and nurse practitioners and behavioral health specialists are the ones who are in charge of a patient's chart. There are other ways, perhaps, that other organizations might provide codes that are not from direct care providers, but that is not something that Oak Street engages in.
Well, I think that answers, I mean, I have to give some thought to it, but I think that answers the question. I mean, if you operate that way, and I would suggest that other people operate that way as well, you're putting full accountability on the provider. So even if they're, well, you're doing two things. First of all, you're taking that decision out of the hands of the person that gets the money, right, so to speak, right? So the organization that should be collecting money, they're the ones incentivized technically to overcomplicate the patients. You take that decision out of their hands and you say, no, you're actually not going to have anything to do with this. We're going to give that to the doctor. And then you're also by doing that, you're also putting full accountability on the doctor. So even if the doctor were to get pressure from an outside department or something like that, it shouldn't really work, because the doctor would be directly liable if their name is on, all those codes. And if the policy is that you're the one putting in that code, right? So it seems like you're putting both a carrot and a stick into place.
I think you touch on something really important, which is the word that we've been talking about for the last how many minutes we've been on your podcast together: accountability. Our doctors and our organization, and I should also add nurse practitioners, because they're a big part of what we do as well. But our providers put their own expertise on the line and have the confidence in themselves to keep our patients, as we say, happy, healthy, and out of the hospital. I don't know if that is a sentiment that is shared across the primary care spectrum in the United States. And we have to do a lot of teaching of new providers that come to Oak Street Health on how to practice inside of value-based care. It is different, and you have to have the courage of your convictions and skill set to be able to do it.
Yep.
But that's also, Mendel, why if you meet an Oak Street Health doctor, you are talking to the creme de la creme. I love traveling around the country and talking to our doctors on the ground, and our nurse practitioners and our behavioral health specialists and our social workers. They are dedicated to caring for the communities that we put our centers in.
Fascinating.
Which, by the way, mostly are communities where the primary care world has run away from. I like to say we put our centers where primary care runs away from, we run to. 77% of our centers across the country are located in health professional shortage areas.
Wow.
Right? We are a health equity organization solely by that measure, and that's not the only measure I would put us up.
What are you, in your mind, what are you doing different? If people are running away, it's obviously because they can't operate successfully. So what are you guys doing differently?
So one of the things is we have great results, right? We were the number one we were the fourth highest saver in the Medicare Shared Savings Program.
Wow.
2020 out of 513 organizations.
They put that number out, right? Of actually how much you saved, right?
Yep.
How much did you save?
I don't know off the top of my head. I know the rank. We were fourth out of 5.
Huge. That's huge.
In 2020, that is huge. And we were near the top and at the top in the first year of what is now the CMMI ACO REACH model.
Yep.
And we get these great results, right? You're talking about 51% reductions in ED visits and hospital admissions versus Medicare benchmarks. And then our patients really like us. 94% of, this is a recent number, 94% of Oak Street patients like the care that they received from their provider.
Yeah.
So listen, our patients are really, really sick when we first open a center, which usually has no patients in it, right? And we opened 50 last year, and we're aiming to open, I think, 35 or 40 again this year.
How many do you have total right now? Do you know?
172 is 21 states, about 225,000 Medicare beneficiaries.
Wow.
We're aiming to get 300 centers by 2026. But my larger point is, after some time of our patients being under our care, they get better. And that's the courage of the convictions of the providers who work at Oak Street Health.
It's amazing. I have another policy question for you, because your brain works this way. So my other concern, or I shouldn't say concern, but my other question when we talk about value-based care is that if you do such a good job, because again, we're going back to that PMPM, right? That's the way that you are successful. Because you say, you know what, I'm going to take full responsibility. You pay me this amount. You would be paying more if we would just be doing straight fee for service. So you're saving the plan money, you're saving Medicare money, right? And then the most beautiful thing about it, obviously, is that your values super align with the patient, right? I'm not incentivized for you to break your leg. I'm incentivized to make sure that that I spend the $50 to get a bar in your shower so that you don't slip and fall, because then I'm paying $150,000 for a hip replacement surgery, right? So you super align with the patients. But the question that I have is, if you do such a good job, right, at what point do you kind of reevaluate that PMPM and say, okay, well, you guys did a great job, but now across the board, your patients are a lot less costly to manage, and therefore we're going to start paying you way less. And now maybe the whole business model kind of tanks. Any thoughts?
Well, so I would start by saying we have not made a profit at Oak Street Health yet. And so that's one place that I would start. There's a long trajectory of growth that needs to happen. And we need to prove our model that works over and over again and over time. We need to earn the trust and respect of the communities that we operate in. And I think that that's probably a question that we would think might happen as a health policy community over time.
Yeah.
We're certainly not there yet.
Yeah. I think the other point to counter is that there's always patients coming into Medicare or coming into the various plans where they've been managed by previous either relationships, doctors, providers, organizations from payers. And so you'll probably always, to a certain extent, have the data to say, this patient was doing much worse, and now that we're managing them properly, you can immediately see that shift. Probably
that's the whole point of the HCC coding, risk adjustment structure. It is sometimes hard when our patients come in with no previous HCC footprint.
Mm-hmm.
And then it takes a good year or two for us to get that payment correct with the agency. But it does happen over time. Again, it's because we're taking the risk and the accountability, and we are willing to take that not so fortuitous dynamic in the beginning for the realization that we have the confidence that we can get them.
Yeah. What I think is so amazing about it, and it's clear from kind of what you're talking about, that this is where your providers are, is that with accountability comes responsibility, and with responsibility comes authority. If I take the responsibility to and the accountability to care for this patient, that gives me the authority to make those calls. You talked about earlier how your providers are confident and that you have the creme de la creme because they're able to actually use their expertise and make a call and say, this is what I think is best for the patient. And it needs to be so much broader and more comprehensive than in a fee-for-service world, where the behind the scenes is, hey, just bill as much as you could bill. That's the name of the game, because, as a hospital, this is how we make our money, or even as a doctor, this is how we make our money. So you have one job, write things. That's your job.
Well, also you make a very important point. And that is that there is this American, I call it the fee-for-service flywheel, right? And Senator Sheldon Whitehouse of Rhode Island has been from the dais at various committee meetings talking about this too. And I know this also because we have 4 centers in Rhode Island, one of which the senator has visited. But when you are on that flywheel of 15-minute appointments, and listen, I am not a physician, I am not a nurse practitioner, I'm just a health policy advocate. But when you're on that flywheel, it makes it really hard to focus directly on your patients. And so our patients on average, see us 8 times a year versus 3 in regular Medicare primary care. We have much longer appointments. We limit our patient panels for each of our providers to about 500 versus the average of 2,000 for primary care. So our doctors and nurse practitioners can reach out to their patients when they're not in our center. Are you lonely? Have you seen your grandchildren? Have you been able to get out to the supermarket? Have you gone to church or mosque or synagogue or whatever your chosen house of worship is? Would you like to come into one of our centers for a community room event and do yoga or bingo? We have community rooms, which are kind of like senior centers in each of our facilities. Because we now know, and the Surgeon General just said last week, right? Loneliness is an epidemic with seniors in particular, and equal to a pack and a half of cigarettes a day.
From what perspective? From
like an overall health perspective, like equated to that in several studies. And so we work on that, because if you are anxious, lonely, or depressed, you are not going to keep up with your hypertension or diabetes care management, right? And so value-based care allows us to deal with those other drivers of health that will make people healthier over the long term.
Yeah.
There's one other important point here, Mendel, and that is that when you have fewer patients and you have much more deep relationships with them, as our providers would be the first to tell you, you have much more professional satisfaction. And you get to be a healthcare provider, which is what you went to school for, rather than a cog in the wheel of 15-minute appointments.
Yeah, absolutely. It's a certain freedom to say, use your education and use your knowledge and make a call that's actually in the best interest of the patient and in the patient's overall care. I think it's an incredible thing. So we kind of jumped all around. We talked about that. I think it's kind of clear a lot of the work at Oak Street Health. But just quickly, what attracted you to Oak Street Health 19 months ago? And what would you say is your primary work there?
So I really love, right? There's that we put our centers in places where the primary care system has run away from. Like I said, I've spent the first 7 years of my career in downtown Passaic, New Jersey, which is one of the lowest income communities in the country, and have had a real dedication to those communities throughout my career. I also, when I was at United States of Care, I formed a really great relationship with former CMS Administrator Andy Slavitt, who founded United States of Care. I was there during the early stages of the pandemic, trying to help America think about how to get their hands around the policy choices that needed to be made. That's a whole other conversation for
part 2.
A whole other time. That's part 2. But Andy is uniquely situated in American health policy between the public and private sectors. And you can have an entire debate about the future of American healthcare, single payer or not, private sector versus public sector. But in order to be a important and critical thinker and operator inside of our current system, you need to have an appreciation for both. And I saw that Andy had done this in an honorable way, filled with integrity. And I saw that Oak Street was putting these centers in this way, and it was really exciting. I also really believe in value-based care. I believe in accountability in my own life, both personally and professionally. And I think that most structures, and certainly the structures that are receiving taxpayer resources, should be held accountable for high quality care. And that's what brought me to Oak Street. And then the other thing, which we touched on, I was the first government affairs professional at Oak Street. I helped our C-suite understand the value of and the importance of government affairs and thought leadership and things of that. I help my colleagues do that. I give my colleagues, I'd like to think, a certain level of morale boost that I'm bringing their work into, to quote Hamilton, the room where it happens, right? And that's very personally meaningful to me. I now have a small team, and a great woman who works on our team here at Government Affairs. And so, I'm excited for what the future is for accountable care and for Oak Street in general.
Fantastic. Final question. You guys were just acquired by CVS. How did that change things? What does that look like from an organization the size of Oak Street Health to get bought by an organization the size of CVS, and specifically in your work?
Yeah, so you'll forgive me that we're only a week into the close. We closed, 1 week ago, 2 hours ago.
Oh my goodness!
So
You guys pop champagne? What happened?
Listen, there is a lot of excitement. Personally, and I think a lot of my colleagues share this view at Oak Street. We are excited for the breadth and scope of CVS. I mean, they have 9,000 stores across the country, right? And we only have 172 health centers right now. And so that breadth and scope to bring the Oak Street Health model to more communities across the country, I think is very exciting. Oak Street has a long established and smart government affairs operation, both at the local, state, and federal levels. And I am excited to learn more about it, and hopefully also help CVS understand, the CVS government affairs folks understand what it is that Oak Street does, and for me to understand what they do. So if you check back in a few months, I might have a more built out answer for you. But
I think we will. Well, Andrew, I think we could definitely easily do another hour. Maybe we will have to come back for part 2. But I really appreciate you sitting with us today. I think it's incredible the work that you're doing, and I think it's very clear, as someone that talks to leaders across healthcare across the country, it's pretty clear very quickly when you talk to people, whether they're just kind of running talking points and they're just kind of espousing ideas that are relatively shallow, or if they're really, they live what they say and they mean what they say, and there's a certain passion and a certain depth there. And I think it's very, very apparent from you. So I think congratulations, first of all, to Oak Street Health for picking you up 19 months ago. And I think you're going to obviously be integral to the continued growth through the CVS expansion and acquisition. And I'm excited to see all the work that you do ahead. Fantastic.
Great. Thanks, Mendel. That's very personally meaningful to me also to hear that from you. Thank you.
Absolutely.